Good afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Just few brief announcements before I introduce our today's speaker. Please ensure that you're muted. In order to receive the CME credit for attendance, please see the chat room for instructions. And you need to sign up for this credit. And if you've not signed up already, please message Debbie Lovejoy. And if you think anyone else is interested, please reach out to her as well. If you have any questions or comments during the presentation, please use the chat room or you can unmute yourself at the end, and I will also moderate the session. And the recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And today I have the absolute pleasure of introducing Dr. Akira Lindy Dupuy-McCauley. She received her medical degree from Wayne State University School of Medicine, Michigan, and then completed her internal medicine residency and chief residency at Beaumont Hospital in Michigan, and then her pulmonary and sleep medicine fellowship at Mayo Clinic in Rochester, Minnesota. She's currently an assistant professor of medicine at Mayo Clinic and a consultant in the Division of Pulmonary and Critical Care Medicine. Her research has primarily focused on obesity-related lung disease, sleep-disordered breathing, and perioperative sleep medicine, and she has lectured nationally on these topics. She's also received many awards, including Distinguished Chest Educator twice, the Chest Network Rising Star Award in 2024, and multiple Mayo Clinic teaching honors. She has also authored over 20 peer-reviewed publications, book chapters, and consensus statements. And most recently, she co-authored a 2025 Society of Anesthesia and Sleep Medicine opinion paper on high-flow nasal oxygen therapy in post-op sleep-disordered breathing. Dr. McCauley has also held leadership positions in many national societies, and I've had the privilege of knowing her through CHESS, and it has been an absolute pleasure to witness her contributions to pulmonary and sleep medicine, besides her being also an amazing human being. Thank you so much for being with us, Kara, and without any further delay, I would like to hand it over to you to share your expertise on central sleep apnea, a complex challenge in pathophysiology, diagnostics, and treatment. Thank you again.
All right, thank you so much for the very, very nice introduction. And I see my other friend Lauren is on here too, Dr. Tobias. So it's nice to see you guys and nice to meet you all, to the people who I don't know. Thank you for having me today. I love to talk about central sleep apnea, so it's a pleasure to give this talk to you all. I'm going to cover some of the more fundamental aspects of central sleep apnea and kind of lay the foundation hopefully for understanding some of the current controversies that we have, which I think might be a talk that you guys are getting later. All right, I have a CME slide for you. So this is the number for CME if you need it. I don't know if someone wants to put that in the chat or something, but all right. And I have a couple of disclosures. I have done some consulting for Respicardia, and they make the transvenous phrenic nerve stimulator system remedy for treatment of central sleep apnea. And then I'm also going to be talking about a couple off-label uses of pharmaceuticals, namely acetazolamide and buspirone. So as I mentioned, we're going to just kind of start with some fundamentals, talking about all of the different kinds of central sleep apnea, and then the pathophysiology of each of these. And then we'll discuss a little bit about the treatment options as well. And then I have some cases at the end. I hope that we have time to go over those. We'll see what we have time for. All right, so as most of you probably already know, central sleep apnea is what we call a disordered breathing event that occurs where there is decreased or absent airflow and decreased or absent effort. And so you might see this on a PSG, so we have no airflow, no effort here. But central sleep apnea can be due to many different reasons. There's a lot of different risk factors of varying etiologies. So age, we don't really know if it's the aging process itself or the increasing comorbidities that come as people age. Being a man is a risk factor because testosterone can have some effects on chemosensitivity. Heart failure, atrial fibrillation, valvular disease, particularly if it's regurgitation, that would be the most common scenario. Stroke, renal failure, medications, and then there's a variety of other random conditions like spinal cord injury and acromegaly that can cause central sleep apnea. We have some data. This is wrong, but I kept it in this uh, talk because I think that people think that central sleep apnea is a lot rarer than it actually is. So if you look at this data from the Sleep Heart Health study, they calculated the prevalence of central sleep apnea in just about 1% of people who are presenting to sleep clinic. But I think that we know that that number is actually a lot higher with more recent data. And it's certainly higher if you look at certain populations, like people with heart failure. So that's a really common consult that we get here at Mayo, being a referral center, is, I got diagnosed with sleep apnea, treatment is not going well, what's going on? And, in many of these cases, it's because people have central sleep apnea. And part of it is just because it's really hard to diagnose. But I also think that people just aren't aware of how common it actually is. This is actually a more recent paper that came out this year about the prevalence of central sleep apnea. Part of the reason that it's difficult to diagnose is that we usually just base the diagnosis on the apneas and we ignore the hypopneas, or kind of assume that the hypopneas are obstructive. This paper went and scored all of the apneas and hypopneas for over 4,000 sleep studies. And if you were just going based on the apneas, the incidence of central sleep apnea in this cohort was 5%, but when they scored the hypopneas as well, it jumped up to 20%. And so again, there's still more work to be done in this area, but I think that it's just important to know that central sleep apnea is not some rare thing that, nobody ever sees. It's actually a lot more common than we realize. Central sleep apnea is not one thing. That's another really important point. It's actually a group of disorders. So it's really hard to make blanket statements. And I think that's where a lot of problems with diagnosis and treatment come into, because we're trying to fit a whole group of disorders into this one box and, talk about the whole group like it's one process when it's really not. So we have primary central sleep apnea, which we also sometimes call idiopathic central sleep apnea. So, we are not really sure what is causing it. And then we have secondary central sleep apnea, and that can be in the form of Cheyne-Stokes respiration, like what we see in patients with heart failure, high altitude periodic breathing, treatment emergent central sleep apnea that happens to somebody who has obstructive sleep apnea when they're on PAP therapy, central sleep apnea due to a medical disorder without Cheyne-Stokes respiration. And so sometimes we'd classify, a central sleep apnea that occurs as a result of stroke in this category. And then central sleep apnea due to a medication or substance. Most commonly, that's going to be opioids, but there are a few more medications that can cause it as well. These types of central sleep apnea can be further stratified into their pathogenesis, which I think it makes a lot of sense to think about it in these terms, because then you can kind of get a better understanding of what treatment options are available and which ones are most likely to be helpful. So we have high loop gain, and the ones that would fall in that category are primary or idiopathic central sleep apnea, Cheyne-Stokes, high altitude periodic breathing, treatment emergent central sleep apnea. Then we have failure of rhythmogenesis, where there's something wrong with the breathing center in the brain. That is usually going to be central sleep apnea due to medications, or it can also sometimes be a structural lesion. For instance, if you have a stroke that occurs in the respiration center of the brain and disrupts the rhythm in that way, or if there's a mass or Chiari malformation, those can all cause disruptions in the breathing signal that's being sent out. And then there's other. So central sleep apnea due to a medical disorder without Cheyne-Stokes respiration can fall in the other category. And the other category can be further divided into high loop gain with high plant gain and pseudocentral sleep apnea. So high loop gain with high plant gain happens in people who have chronic hypercapnia. It can happen in spinal cord injury. And then pseudocentral sleep apnea, I like calling it pseudocentral sleep apnea because when you look at a polysomnogram, you still see no airflow and no effort. But as opposed to the other types of central sleep apnea, this is because the brain is sending the signal. It's just that the body cannot carry out that signal for respiration. So this happens in people with neuromuscular weakness or really severe thoracic cage restriction. So again, their brain is sending the signal, but the muscles and nerves cannot carry it out. The clinical presentation of central sleep apnea can range very widely, just as in obstructive sleep apnea. I like to talk about this too, because I think the traditional teaching, or what we were told years ago, is that, oh, people with central sleep apnea aren't sleepy. But I haven't found that to be true. And I think we're kind of starting to recognize a little bit more about the symptoms of central sleep apnea. So they can still have sleep fragmentation and excessive daytime sleepiness and poor sleep quality, just like people with obstructive sleep apnea. You might see, people waking up feeling like they're taking a bunch of deep breaths. I've had that before. They can still have morning headache or some of these cardiovascular symptoms at night as well. And then I typically question the bed partner in a little bit different way than for somebody who I'm suspecting obstructive sleep apnea. Obstructive sleep apnea is much more obvious because you have loud snoring and then, periods of time with no snoring and then that resuscitative snort, in many people. Central sleep apnea is a lot more subtle. So I usually ask people, are there ever times when your bed partner appears to not be breathing and you want to go and poke him and see if he's still alive? Or sometimes I ask about just irregular breathing patterns. Are there times where he is taking a lot of deep breaths and then, appears to stop breathing or breathe a lot more shallow? So it's just a little bit more subtle, and I think a little bit harder to recognize by the bed partner just because it's typically not loud. To diagnose central sleep apnea, to do this effectively, you really need an in-lab sleep study. Allegedly, there is a paper out there stating that the watch-PAT sensitivity and specificity for detecting central events is 67 and 100% respectively. But clinically, and this is my own personal assessment, but clinically, I would say that the specificity is not 100%. Just because there's been a variety of patients who I have, done a home sleep apnea test on. They unexpectedly have central sleep apnea. I bring them in the lab. It turns out they don't have central sleep apnea. They just have really severe obstructive apnea with repetitive breathing pauses. So I think, important to know that we're still learning about the sensitivity and specificity of home sleep apnea testing for central sleep apnea. Nothing is FDA approved to diagnose central sleep apnea in the outpatient setting. And so polysomnography is the gold standard that we have and most likely to get you an accurate diagnosis. The other problem with central sleep apnea is that even if you do a polysomnogram, it's sometimes hard to diagnose because of what I was saying earlier with hypopneas. Central apneas are fairly non-controversial, because you really see very little or no effort. But central hypopneas are a lot harder to detect because you typically do have some effort there. It's just more of a reduction in effort rather than a lack of effort. So they're very hard to distinguish from obstructive hypopneas. And as of right now, we don't really have a standard way of differentiating these events. Hypopneas have been a little bit controversial in general over the years, and the definition has changed a lot. And it recently changed again. So the most current way that we're supposed to score hypopneas is based on a 30% reduction in airflow, duration of 10 seconds, and then associated with a 3% oxygen desaturation from baseline or with an arousal. The optional method of scoring hypopneas is just the same reduction in airflow and time qualification, but with a 4% desaturation. And now you have to have both of these, the 3% and the 4% numbers in your reports. CMS, Medicare, and Medicaid only reimburse based on the 4% rule. Some commercial insurance is based on the reimburse based on the 3% rule. So I don't know, this is something that's been in flux for a long time. And on top of that, scoring hypopneas as obstructive or central has never been mandatory. And so what the AASM says about hypopnea classification as of right now is that if it has any one of these features, flattening of the inspiratory portion of the nasal pressure transducer, snoring during the event, or thoracico-abdominal paradox, you can score it as obstructive. If it doesn't have any of these features, you score it as central. But my project that I did as a fellow was actually testing this out, and we found that it was about 67% accurate, which isn't wonderful, but also isn't terrible. But The really big problem is that there was just so much inter-rater reliability. And so people tend, individual people tend to score these hypopneas really differently. And, so to me, that just makes this not a very reliable method of scoring events. There's been work done over the years looking at chest wall EMG and machine learning algorithms and things like that, but none of those has been adopted into clinical practice, probably because they're using extra sensors and things that we're not always measuring or not already measuring during a sleep study. So it would be nice if we could have some sort of visual criteria to define the hypopnea, but that is a work in progress. But it's really important though, because hypopneas make up 60 to 80% of the disordered breathing events. And with some of the research that's coming out now, and a paper that I'm hopefully about to publish, we're learning that if you don't classify hypopneas, you're really going to underestimate the amount of people who have central sleep apnea. So anyway, that's kind of one of the current things that people are working on in this space. But being that we don't classify the hypopneas as of this moment in time, sometimes that leads to misdiagnosis, underdiagnosis of central sleep apnea. All right, so I'm going to talk a little bit about each of the mechanisms of the different types of central sleep apnea here. So first, high loop gain. This is a term that comes from the electronic world, and it essentially describes how different inputs into a system affect the output. So the output in this case is homeostasis or pH, oxygen and carbon dioxide levels. And then the inputs to the system in this context are the brain, the lungs, and the heart. So in the brain area, we have the central and peripheral chemoreceptors here. And then the lungs, there can be a couple different things that can happen in the lungs that influence the loop gain. One is stimulation of the stretch receptors that can sometimes come from pulmonary edema. But the other thing about the lungs is, how much change in carbon dioxide are you getting for change in alveolar ventilation? And then in the heart, you have blood circulation time. So if you have anything that is disrupting any of these systems, you're going to get a higher loop gain, and that is going to predispose to central breathing pauses. And this is the way that that can happen. If my slide will advance. Okay, here we go. So say you are a person and this is your baseline carbon dioxide, and this is just where your body wants your carbon dioxide to be. We all have an apneic threshold, so a point at which if the carbon dioxide falls below the apneic threshold, you're going to have a breathing pause to make it rise up again into the normal range. So if you are a person who lives very close to your apneic threshold, then you can be breathing along here and, some sort of stimulus happens and causes a little bit of hyperpnea, and then the carbon dioxide gets blown down below the apneic threshold, and then you have a breathing pause. And then typically what will happen is that during this breathing pause, whatever stimulus happened in the first place to create the hyperpnea will come back, and then you'll get more hyperpnea and a breathing pause, and then hyperpnea and a breathing pause. And it's hard to get out of that cycle unless there's some sort of thing that disrupts the cycle, like waking up or something. And this is why we commonly see really high AHIs in people with central sleep apnea from high loop gain, because you kind of get in this disrupted cycle and you can't get out of it. And this would be opposed to somebody who is living further away from their apneic threshold. So if you are in this situation and your carbon dioxide is way up here, you can be breathing along and have a stimulus and a little bit of hyperpnea. And yeah, the carbon dioxide is going to go down a little bit, but it's not going to go below the apneic threshold. And then you're going to keep on breathing normally. So, part of this is just kind of, intrinsic and having to do with the carbon dioxide that the patient is living at. And then, of course, when you're have a prolonged mixing time or circulation time, as would be the case with arrhythmia or valvular disease or heart failure, the brain's going to be getting delayed signals about the levels of oxygen and carbon dioxide, and that's going to, make the loop gain higher. So the first one in this category is idiopathic or primary central sleep apnea. This is a diagnosis of exclusion. Allegedly, this is about 4 to 7% of the central sleep apnea patients who are referred to sleep medicine. So as I was saying before, I think some of our numbers are probably need to be rethought, but this is the data that we have as of this moment in time. So it's a less common cause of central sleep apnea. However, there was one study that came out that discovered that 27% of people who had been given a diagnosis of idiopathic central sleep apnea ended up having AFib. So usually when I see somebody with idiopathic central sleep apnea, I will get an echo and an ECG if they haven't had one recently. I usually question them too about, palpitations, fluttering, things like that. Sometimes I get an MRI of the brain as well if it seems like there could potentially be other symptoms like headaches or any other sort of neurological symptoms, but I don't always get an MRI. It just depends on the situation and the patient. Central sleep apnea with Cheyne-Stokes respiration. This is a specific diagnosis. You have to have an AHI of at least 5 with over half of the events being central in nature, which is true for all of the different types of central sleep apnea. But the thing that's different about this is that the respiratory cycle has to be at least 40 seconds. And this makes a lot of sense because Cheyne-Stokes is partially due to this prolonged mixing time that comes in patients with heart failure. And so when you have a longer mixing time, you're going to have a longer respiratory cycle. And so in addition to being affected by the intrinsic chemosensitivity in the peripheral and central chemoreceptors and the mixing time, it can also be exacerbated by pulmonary edema, which activates the stretch receptors in the lungs and stimulates respiration. And that can also kind of lead to hyperpnea and start off this dysfunctional cycle of breathing. And it confers a poor prognosis, but we don't really know why as of now. And we also don't know if treating central sleep apnea in this population is helpful. We often do if it's severe or if it's causing a lot of oxygen desaturation, but we don't have complete data on clinical outcomes in this scenario. High altitude periodic breathing is another form of central sleep apnea that has to do with loop gain. This is more of a increase in chemosensitivity that comes in response to a hypoxic environment, though. So it is a different mechanism, even though it can be classified in the high loop gain category. Over 3,000 meters, most people are going to have high altitude periodic breathing, but the presence and severity can vary. Some people will have it mostly when they first ascend to altitude, and other people it will be very persistent. You can also have it at lower altitudes, just depending on the patient and their risk factors. Things that are going to predispose to central sleep apnea at sea level are also going to put you at higher risk for high altitude periodic breathing. But this usually appears a little bit different on a sleep study than Cheyne-Stokes respiration would. This is usually a clustered breathing pattern, so you'll have a couple of normal breaths and then a breathing pause, and then a couple more normal breaths and a breathing pause. I have examples of all these later, so don't worry. And of course, it's a shorter cycle duration than Cheyne-Stokes. And then treatment emergent central sleep apnea, the incidence, the average is about 12%. If you look at all the studies, it's anywhere from, I think, 8% to 20%, if I am remembering correctly. So anyway, it's pretty common. The risk factors are male gender, underlying severe obstructive sleep apnea, use of higher pressures on positive airway pressure therapy, and then you can, other conditions like heart failure, AFib, renal failure, use of opioids, high altitude, all of these other things that can predispose you to central sleep apnea can also be risk factors for treatment emergent central sleep apnea. In this one, we really know nothing about clinically. So I typically don't do the same workup that I do for people with underlying, central sleep apnea so if you have treatment emergent central sleep apnea, I don't typically do the echo and things like that. An important thing to note is that treatment emergent central sleep apnea does not only happen in positive airway pressure therapy. It's also been described with mandibular advancement devices, Inspire, tongue protrusion devices, the Provent, which has since been discontinued, but tracheostomy and surgery. So some of these have prevalence data, but the other ones don't. They're more case reports. But here for hypoglossal nerve stimulation, the last figure that I was able to get was 3.3%, and then here about 2% for maxillofacial surgery. So just to know that this can happen with other therapies as well. So for failure of rhythmogenesis, this basically happens if you have something that is actually disrupting the neurons that make the breathing pattern in the medulla. And the most common thing that we see causing this type of central apnea is opioids. However, there are case reports of baclofen, valproic acid, and sodium oxybate. And actually, I saw this recently in a patient with who was on tizanidine, which is not shocking since baclofen can cause it. But anyway, so there are a few other medications that can cause it, and probably some that we haven't really recognized yet. But this is caused by depressing the inspiratory neurons in the Prüm-Botzinger complex. Unfortunately, the Prüm-Botzinger complex has opioid and GABA receptors, and so it is susceptible to these types of medications. You can see a couple different breathing patterns with opioids. I think if you're asked this on a board, you would probably choose ataxic breathing, which is, if you think about somebody walking in an ataxic manner, they would kind of be wobbling all over the place. Ataxic breathing is basically just a very disorganized breathing pattern, breaths of different sizes, pauses of different intervals. And then ticagrelor, which is a platelet inhibitor, this is unknown mechanisms of why it causes central sleep apnea, but actually 30% of people who take ticagrelor are going to have moderate to severe sleep apnea. And I've been waiting my whole career to find someone on ticagrelor and be really smart and be like, yes, that is the cause. And it finally happened like a couple of weeks ago. So I was really, really waiting for that one. And, it finally paid off in the end. And I hope I sounded smart. There are structural causes of failure of rhythmogenesis as well. With a Chiari malformation, when you have herniation of the brain stem through the foramen magnum, that can compress the medulla and alter the respiratory function. And then stroke, especially if it's in one of these areas in the medullary tegmentum, the lateral medulla, or the cerebral hemispheres bilaterally, or the brainstem, you can get central sleep apnea. I do see that occasionally. I've seen a few patients with that situation. And then tumors and neurodegenerative disease. It's not something that is strongly associated with central sleep apnea, but there have been a few people that I've seen who are, pretty, affected in their disease process, and who I believe that their central sleep apnea was due to neurodegeneration. And then other. So this is how the carbon dioxide can sometimes affect central sleep apnea. So this is a chart of the change in carbon dioxide and change in oxygen per change in ventilation. Most people are living here on a little bit of a flatter portion of this curve, so that when you have disruptions in ventilation, the PaCO2 doesn't change all that much. But if you are a person who has chronic hypercapnia and you're living more in this area of the carbon dioxide curve, then for a small increase in ventilation, you can really tank your carbon dioxide. And so that can sometimes blow that below the apneic threshold and cause an episode of central apnea. And then pseudo-central sleep apnea, like I said, this is a little bit different because it's not really central. Actually, it's peripheral central sleep apnea. So here, the breathing centers are intact. It's just due to neuromuscular weakness or some sort of restriction in the breathing, the motion of breathing cannot be completed. And I think it helps to understand all of these mechanisms in order to understand what the treatments are and why you might choose one over another in different scenarios. I have a question for you all. This is a hard one, I think. Which of the following statements best reflects policies from the AASM clinical practice guideline on central sleep apnea treatment? The reason this is a little bit hard, I think, is because this is actually not officially out yet. It is available, ahead of publication, but I wanted to put this in here because I don't think this has really become, widely adapted yet. So the first option, ASV should be avoided in patients with heart failure with reduced ejection fraction and predominantly central sleep apnea due to increased mortality risk. Did they say CPAP is the first line therapy and has demonstrated mortality benefit in heart failure with reduced ejection fraction and central sleep apnea? In the treatment of high altitude periodic breathing, CPAP is considered first line, but supplemental oxygen and acetazolamide may also be considered. And the fourth one is bilevel PAP therapy without a backup rate should not be utilized for treatment of central sleep apnea in patients with high loop gain. I don't think we have any sort of response system, so I'll just let you think about that for 1 second. Does anyone want to shout out what they think the answer is?
Or you could put the answers in the chat room too.
Oh yeah, or put them in the chat. I don't have, oh, here's, okay. Okay, oh, you guys are too smart. All right. The last time I gave this talk, like a month or two ago, a lot of people got this one wrong, but people are on the right track here. So bilevel without a backup rate should not be utilized for treatment of central sleep apnea in patients with high loop gain. So that is true. And I kind of put that to highlight this big shift in the way that we are thinking about patients with reduced ejection fraction. So in the central sleep apneas with high loop gain, these are the available treatment options: CPAP, oxygen, ASB, pharmacological therapy, and then phrenic nerve stimulation. And when I used to give this talk, I used to say, contraindicated in ejection fraction less than or equal to 45% because of the SERVE-HF trial in 2015. But if you look at the most recent clinical practice guideline, they actually, they don't recommend it without hesitation. But basically, the language is kind of opening up for the possibility of using ASV in patients with heart failure with reduced ejection fraction. I'm not going to go over all of these in detail because I don't think that we'll have time to do that. But I wanted to bring up a couple of different things. So they basically recommend, CPAP is okay. They recommend BiPAP with a backup rate over no BiPAP. And they suggest against use of BiPAP without a backup rate in primary central sleep apnea and the other high loop gain central sleep apneas. And they suggest using ASV over no ASV in primary central sleep apnea due to heart failure, and then medications and et cetera. So their remarks were devices that deliver ASV have different proprietary algorithms for sensing and responding to respiratory events. Safety data is not available for all devices on the market. Increased mortality was associated with only one device in patients with heart failure with reduced ejection fraction, and this device is no longer being manufactured, which is all true. They tried to look at this again with the Advent HF trial, which was going on, unfortunately, during COVID, and they were using the Respironics device. And so COVID happened, and I think that disrupted enrollment. And then the Respironics device that they were using got recalled, and then that was kind of the final nail in the coffin. And they had 6-month data, which didn't seem to show any concerns about increased in morbidity and mortality, but the study was underpowered, and so I think it's encouraging, but probably not definitive in the results. But I think it is starting to change our thinking a little bit, though, about prescribing ASV in this situation. Here's some more. I kind of included all the treatment guidelines. I don't know if you guys are gonna get these slides, but I'm happy to share them if you would like them, because it has kind of the highlights from those guidelines. But check them out if you have time. Most of the data from CPAP in central sleep apnea comes from the CAN-PAP trial. That's kind of the one that most people talk about. Initially it didn't show any effects in people with heart failure. However, a lot of these people, did not have the AHI controlled. And so if you take out the people who actually had a AHI that was in the, mild range, then they did have increased transplant-free survival and better LVEF. Is an increase of 3.6% clinically meaningful? Probably not. But I take this to mean that, maybe CPAP can be beneficial in patients with heart failure and central sleep apnea, and hopefully it's not harmful. Supplemental oxygen, there are a handful of studies about supplemental oxygen, mostly in patients with heart failure with reduced ejection fraction. And it shows that it reduces the AHI at least 50% often. However, if you've got an AHI of 60 and you reduce it by 50% and now your AHI is 30, it's not always super helpful. And it's not effective in all patients. I think, my experience clinically is that some people it works really, really well for, and all the central sleep apnea melts away. And then there's other people who it works not at all for, and the other people where it's somewhere in the middle. So I think it's a reasonable thing to try, but it doesn't work well for everyone. And we lack data on, is it helpful for mortality and things like that. Supplemental oxygen is the first line therapy for high altitude periodic breathing, though. That is the only form of central sleep apnea that it's the first line therapy. So that's important to note. Just because the reason that it's happening in that situation is because of the hypoxic environment. So taking away the hypoxic environment fixes the problem most of the time. ASV is another therapy that works pretty well for a wide variety of patients with this type of central sleep apnea. It's reasonable to try in all of these conditions, primary treatment emergent central sleep apnea, opioid-induced central sleep apnea. You just have to make sure that the patients aren't hypoventilating. This is not a device that you want to use in anybody who has hypoventilation. There's some studies about using ASV in high altitude periodic breathing. Some show that it's effective, some suggest that it's not effective. I think it's reasonable to try, and I think the practice patterns of a lot of people at altitude, they do tend to try ASV. So anyway, some conflicting data there. This is how the ASV works. It's basically targeting minute ventilation. And so it will look at the patient's own breathing pattern. The ResMed device is a 3-minute window. And so it will calculate their minute ventilation, and then it will try to achieve that same minute ventilation. That's why it's not good to use in people who are hypoventilating, because if your minute ventilation is not good, then the ASV is going to give you a minute ventilation that is also not good. So what might happen in this case is that you have a fixed EPAP and a variable IPAP. When the patient is having a period of apnea, that IPAP is going to increase and try and force some respiration here. And then when the patient is in a period of hyperpnea, the IPAP will back off again, and so on. And so eventually the breathing pattern evens out. So it works well in many cases. This is just data from the SERVE-HF trial. This is why that there was concern with the ASV in patients with heart failure, because they found a pretty significant increase in mortality in people who are using ASV. However, a lot of these people had obstructive sleep apnea, and the obstructive sleep apnea wasn't controlled, and the compliance with the devices was not good. And so, there was some things about the study, as with all studies, that were suboptimal. And so that's kind of why this has been called into question. So I'm glad that we're looking at this again. But that was the original data. It was real and actually a pretty significant mortality risk. That's just a statement about Advent HF, which I already told you. There's a couple of medication options that you can use for high loop gain. Acetazolamide is probably the one that we have the most data about. Similar to oxygen, it works in some people and not others. Buspirone, there's a couple studies about that. I actually tried it for the first time in a patient, and it didn't work. So, but that's my N of 1. And then Civapixant is a medication that I don't think is approved in the US. It's a medication that's used for pain in Europe. But that is currently being studied with acetazolamide for patients with central sleep apnea and heart failure or atrial fibrillation. And actually, there's multiple sites for that study, and they're currently enrolling. So if you have anyone who might be interested in that, I don't know if you guys are doing the study where you are at Yale, but we are here at Mayo. The theophylline data is kind of similar to acetazolamide for theophylline, but it's got such a narrow therapeutic window and so many potential side effects. And a lot of these people with central sleep apnea have heart things going on. So I think theophylline would be, something that would be very difficult to use in that population. So acetazolamide works by inducing a little bit of metabolic acidosis, kind of pushing that carbon dioxide level away from the apneic threshold. Um, it may also augment diuresis and improve pulmonary congestion if that is present as well. Um, and it may improve plant gain, the pulmonary congestion. And then some people with central sleep apnea and heart failure are a little bit alkalemic, and so it corrects that as well. This is an example of one of the studies that was done in patients with central sleep apnea using acetazolamide. And the AHI improved from 57 to 34. And then there was an improvement in sleep quality and daytime fatigue, but the response was variable, which I think is what we see in clinical practice as well. And they did measure ejection fraction, and there wasn't any improvement there. But data that we have about acetazolamide is somewhat limited. But if you look at all the studies, it does seem like it lowers the AHI. So again, I think it's a reasonable thing to try. This is a couple studies about buspirone. So, there's some thought that these serotonin neurons are involved in central chemoreception, and that somehow buspirone reduces chemosensitivity. And there was actually a double-blind crossover randomized study of 9 patients with heart failure, so a very small study, but it did show that it reduced the AHI by 30% and reduced nocturnal central apnea index by 76%. So it did do a pretty good job in getting rid of the central apneas. And then there was another single center double-blind randomized study in patients with heart failure again. And they did find that buspirone decreased the chemosensitivity, so kind of going along with that theory, to carbon dioxide, and found that the AHI was reduced by 42% and then 79% for the central apnea index. So, this is another study kind of suggesting that buspirone might be effective, at least in patients with heart failure. And this is just the data from that. They actually studied central apnea during the day and at night, and they found that in both cases, the central apnea was reduced. So I think it's a point of interest, but I'm not ready to probably widely prescribe that. All right, so next question. Which patient is an appropriate candidate for phrenic nerve stimulation for treatment of central sleep apnea? Is it A, a 55-year-old with mixed obstructive sleep apnea and central sleep apnea who is intolerant to PAP therapy and has failed CPAP and ASV? Is it a 67-year-old woman with central sleep apnea due to spinal cord injury, a 50-year-old woman with a history of breast cancer who gets regular MRIs to monitor for recurrence and has heart failure with reduced ejection fraction of 40% and central sleep apnea with an AHI of 30? Or is it a 45-year-old man with primary central sleep apnea and AHI of 48, all central events, who is intolerant to PAP therapy? And I should say, who is the best candidate out of these, because there is a little bit of wiggle room with phrenic nerve implantation. And do you guys want to put, oh, I see some are already coming through in the chat. Oh, we have an N of 6 in buspirone. Okay. Yes, I like that. Yeah, I was actually, when I tried it recently, I was adding it to acetazolamide because I had a patient whose AHI was about, I think, 67, and the acetazolamide brought him down to an AHI of 19, but he still felt kind of sleepy. So we were trying to see if we could improve that with the buspirone, but it didn't end up really helping. And then I tried to up the dose, and he had side effects, so it was not ultimately successful. But thank you for sharing that, though. I was trying to talk to anyone around here who had used buspirone and was having trouble finding anyone with experience. So, or intolerance of acetazolamide. Yes, definitely. We have so few pharmacological options that, I think it's appropriate to try these things. And buspirone is a medication that's been around a long time and, probably less risky than some of the other things that we do here. All right, and once again, you guys are correct. So it would be D. This has changed a little bit. Actually, I meant to change the slide. I think I changed it in the other version of this talk and forgot to change this one, but it is compatible with MRI now. But I will say, though, getting MRIs with the remedy is a little bit inconvenient. Right now, the interface is such that, it takes special training to turn it on and off. You have to turn it off for every MRI that you get. And, sometimes there are special protocols that need to be done, and you can only do MRIs on certain days. So I actually still have had people who are getting regular MRIs who have decided that they don't really want to deal with all of that. So you can get an MRI, it's just a little bit of a hassle. Yeah, so it's approved for moderate to severe essential sleep apnea. You really should have less than 20% of the total AHI be obstructive in nature. That's what they had in the study that got the device approved. If someone is hypoventilating, this is not an appropriate therapy. This device is not approved for hypoventilation. So this is data from the study that got this approved by the FDA, the initial study. It was 151 patients with central sleep apnea, and 64% of them had heart failure. The other ones were mostly primary central sleep apnea. And at 6 months, 50% had an AHI that was decreased by at least 50% compared to 11% in the control group. 9% had an adverse event, which is kind of high, but the adverse events that happen are typically things that we can remedy pretty, oh, no pun intended, remedy pretty easily. So, discomfort with the therapy or irritation at the infection site and things like that. We did have one patient who the lead got flipped around and we ended up having to replace that. That's only happened in one of our 12 or 13 that we've had implanted so far. And sorry, I'm looking at the chat here. In most cases, are you using medications concurrently with PAP or standalone? That's a great question. And I would say the answer is both. I think I am typically using medications in people who cannot tolerate PAP as, a adjunct therapy. But I have done it in PAP before, say you've given somebody a CPAP and they're not willing to come back for another in-lab titration, or they can't, or, something like that, or somebody is on CPAP and they are doing okay when they're at sea level, but when they go to their home in Aspen, they have issues with central apnea. I think in cases like that, it's definitely appropriate to add to CPAP therapy. But yeah, I think mostly when I'm doing it, it's in people who are not tolerating PAP. So sorry for the interruption here. I like to answer things as we go. So if anyone has a question, just feel free to speak up or put it in the chat. So the remedy, what they discovered in this initial set of patients is that, doesn't seem to increase mortality. And there's a trend toward less hospitalizations, although, it wasn't specifically powered for those things. But they did have a really significant improvement in quality of life, which is something that, hasn't been shown consistently with other therapies, at least. And we have 5-year data. We actually just stopped enrolling for the REST trial, which is looking a little bit more in detail at outcomes of the phrenic nerve stimulator therapy, things like mortality and cardiovascular function and things like that. So hoping to get a little bit more data on long-term outcomes with the remedy device. This is what it looks like. Do you guys do remedy over at Yale? I'm seeing Street nodding. Is that a yes? No, you don't. Okay. Okay. Well then, I don't know. People are usually interested to see this if you haven't already, but I think it's kind of cool. And it's the central sleep apnea's Inspire. So it's our implantable device to treat central sleep apnea. It is a little bit different from Inspire in that failing PAP therapy is actually not a contraindication. Before this clinical practice guideline came out, kind of opening up the option of using ASB in heart failure, this was, kind of a really ideal option for people with heart failure with reduced ejection fraction and severe central sleep apnea who, maybe didn't respond to CPAP or oxygen or medication. And you're, not excited about using ASB, so, refer them straight to remedy. But I am usually using this in the case of people who cannot tolerate PAP therapy. So, kind of like Inspire, even though that's not an official qualifier. But basically, it goes into either the brachiocephalic vein or the pericardiophrenic vein. So it can go down here or down here. And there's a coil with 6 electrodes on it, and it kind of coils up within the vessel. And then you figure out which electrodes have best contact with the phrenic nerve. And it stimulates the phrenic nerve on one side of the diaphragm and leads to diaphragmatic contraction. And so it generates a breath from that. And so this is kind of our newest treatment for central sleep apnea. We've done, I think, 13 patients here, and me and my mentor and colleague, Dr. Morgenthaler, are the ones who do the remedy. We don't do the implantations ourselves, but we are the ones who, are in charge of titrating the device and everything. And I think we've had, mostly a largely positive experience here. I will say that some people take a lot of adjustments to get to the point where it's really working and they're getting a benefit. Similar to Inspire, there's some people who get one adjustment and they're doing great right from the get-go, and then other people where it's a lot more challenging. But I think that most of the people that we've worked with, we've been able to get to a place where they're benefiting from the therapy. So it's still early on. We still have a very small cohort of patients, and we are planning on kind of studying our experience here. But so far, I think it's a reasonable idea. Obviously I'd rather have somebody on a non-invasive therapy if that works, but I think this is a good option, again, similar to what we would do with Inspire for people who can't use a non-invasive therapy and they're, really symptomatic or worried about oxygen desaturation or something. All right, so those are all the loop gain treatments. For failure of rhythmogenesis, if you can withdraw the offending medication, wonderful. I've had some patients who, maybe have a baclofen pump or something like that, and we've been able to reduce the dose and it's given a good benefit, or, morphine pump or something like that. But sometimes you can't take away the medication and you just kind of have to treat around it. ASB can be used in this setting, but sometimes we would preferentially use a BiPAP ST if we're worried about hypoventilation. So a lot of the treatment of these other types of central sleep apnea really depends on, is there hypoventilation or not? And if there's hypoventilation, then really you use non-invasive ventilation. If you have some sort of a thing that you can resect or reverse, you can do that. So a lot of people with a Chiari malformation, if you fix that, decompress that, the central apnea will go away. Patients with stroke, oftentimes this is self-limited and kind of in the acute phase, but there are people who have persistent central sleep apnea after a stroke. Even if it's not in the area of where the respiratory centers are, I think for reasons that are not completely clear. Obviously, if you have a stroke in the respiratory centers, it's probably going to be persistent. And then, of course, any other treatment for central sleep apnea is probably going to be in the setting of hypoventilation and is going to require non-invasive ventilation. So we are studying some new things for central sleep apnea. We don't have a lot out there, but there's a study looking at acetazolamide for opioid-induced central sleep apnea, looking at PAP plus, zolpidem, acetazolamide, supplemental oxygen, and buspirone. The REST trial, that's the one that I was talking about, looking at longer-term outcomes of people with phrenic nerve stimulation, and then the sibopicin and acetazolamide in patients with heart failure or atrial fibrillation that I was telling you guys about. And I think all but the REST trial, I think, are actively enrolling right now and present at multiple sites. And I don't know if we have time for cases really. Let me just show you a couple quick ones, very fast. This is a patient who came to me and all I saw was this overnight oximetry and I really had no other information about him. He was kind of coming here getting worked up for some stuff. So initially, you would think maybe obesity hypoventilation syndrome with, some REM-related OSA, but it turns out that these were all central events, but they were only occurring during REM. So what is up with that? That should not be the case. Typically, central apnea is predominant in non-REM sleep. This is a case of pseudo-central sleep apnea. This can be really hard to recognize sometimes. That's why I wanted to show this case. This person actually went on to be diagnosed with ALS. And what we noticed, so this is his sleep study. I'm just going to tell you what's happening so I don't take too much time. But during wakefulness, he was maintaining his oxygen saturations pretty well. When he fell asleep, they started to decline. And then when he was in REM sleep, you would kind of see this pattern where you have this thoracoabdominal paradox and then nothing. And this was followed typically by a very deep oxygen desaturation. So he went on to get diagnosed with ALS. He had very, very severe impairment of his diaphragm. And so this was actually pseudo-central sleep apnea due to diaphragmatic dysfunction. This is kind of a hard situation to recognize. So I like to show this case to our fellows. Let me see, I have a couple.
We have 3 minutes.
Okay. All right. Well, we should just go to questions. This is what opioids might look like. So here's kind of a clustered and ataxic breathing pattern, all sorts of different amplitudes and things like that. Anyway, I'll answer the questions though, because I want to make sure we have time for those.
Maybe you could share those slides and I could share with everyone.
Yeah, definitely.
Again, thank you so much. I knew this would be an amazing talk. Thank you so much for this amazing, very informative and engaging talk, Kara. Let me see if I have any questions here. There's a comment by Dr. Andrei Zinchuk, who's our central apnea expert here. We don't have remedy yet. We should. I have, yeah, and he has a question here. Do you have a pathway for care for central sleep apnea at Mayo? Wonderful talk. Thank you.
Yeah, so usually, if you have a patient or if someone is interested in remedy, they get referred here, and they just know that if somebody is interested in remedy, they have to be scheduled with either me or Dr. Morgenthaler. And so I don't know if you have a more specific question about a pathway of care, but that's kind of how it happens. If someone's coming for remedy, the schedulers just know that they have to be with,
Oh,
either
thank
one of
you.
us.
Hi. I'm just gonna. So I think my question actually was about central sleep apnea management in general.
Oh, sure.
Do you have some sort of a guide for your clinicians in the sleep center on, okay, so because this is one of those disorders that there's not a ton of evidence um, behind various therapies, and so some of this is art at some point in time, and so I'm just wondering whether your art is codified or whether your art is still uh, sort of like ours, where we do things as we see them.
Yes, it is driven by emotion and following your heart. We don't have a certain algorithm for it, but I try to, give this talk to the fellows or, some version of this information, because I think it helps to, put these patients, in some sort of a framework as far as what the pathophysiology is when you're thinking about treatment. So I encourage everyone to think about it in that way, but it's really hard to have an algorithm because even within these, which I didn't get into, but there are different endophenotypes within each of these phenotypes. And so it does get really complicated. And I think it would be something that would be really hard to make an algorithm for at this point in time. But in my other talk about central sleep apnea, I, kind of talk a lot about how we need to be better characterizing these patients so that we can study clinical outcome, diagnose people more effectively, treat them more effectively, and study clinical outcomes more effectively. And I think until we are better at putting people into these categories as far as what endophenotype of central sleep apnea that they have, it's going to be hard to create any sort of algorithm.
All right, I have a few more questions and comments. Dr. Lauren Tobias says, wonderful talk. Thank you so much. And then we have a question by Dr. Parvati Singh. Based on the case you shared, it sounds like if someone has central apneas in REM stage sleep, you should check for diaphragm dysfunction, maybe
Yeah,
anything else.
I would say, not in all cases because there you can have central apneas in REM. I think that's another thing that people don't always realize is that you can have central apnea in REM, even in a patient with high loop gain central sleep apnea or opioid induced central sleep apnea. The chemosensitivity is reduced in REM, but it's not absent, so it still is possible to have central events in REM. However, this patient was coming and getting worked up for weakness. He's having kind of weakness in his upper extremities. He got pulmonary function tests that suggested diaphragmatic impairment. You see that thoraco-abdominal paradox, which is really suggestive of diaphragmatic weakness. You can lay people down in clinic and see if they're paradoxing right in front of you, which this guy actually was. So I think I wouldn't automatically assume that anyone having apneas in REM would have a diaphragmatic problem, but it's definitely something that you should pay attention to because, like I said, it would be really easy to think that that was an obstructive apnea, obstructive apnea occurring during REM. There's thoraco-abdominal paradox, which can also signify upper airway obstruction. If you would have shown me that oximetry, I probably would have said, yeah, this is someone with OHS or COPD or something like that. So it can be difficult to miss. So I think it's better to be on high alert about these things and do a little bit of workup within the context of the patient if indicated.
Thank you. Along the same line, Kara, if you have central apnea on REM versus non-REM, do you suggest looking at them differently, or how should clinicians interpret, the changes between REM, non-REM in terms of treatment, anything?
I mean, most of the time, central sleep apnea is going to be worse during non-REM sleep
Right.
because there's higher chemosensitivity than during REM sleep. I guess one of the things that I always do, because it causes me to write my instructions about sleep studies a lot differently. I'm always like, please get non-REM supine. I think a lot of us want, the text is kind of, they know that we want REM supine really bad, but I always emphasize, no, we need non-REM supine and things like that. Cause, sometimes that's the place where you're going to see central sleep apnea the most, but, I don't know, the REM non-REM thing. I would say in most people you're going to have more central sleep apnea in non-REM than REM in most kinds of central sleep apnea, except for the neuromuscular stuff, obviously.
Thank you. And one more comment. It's been a great session so far. Great work. Thank you for the knowledge impacted. Completely agree. Does anyone have any more questions? It's 3:03. If not, we will
Oh,
stop here.
okay. Oh, sorry. There was a question about the diaphragm dysfunction, but
That was a question I actually
oh, okay.
about the REM, yeah, the MIP map. Yeah. You answered that question, Kara.
Okay.
Okay, everybody is here saying thank you, and thank you so much, Kara, and thank you
Yeah,
everyone
thanks so
for
much for having me. Yeah, I can send you my slides too.
yeah, and I can share it with the group.
Okay, sounds good.
Great.
All right. Thank
Thank
you,
you
everyone.
again.
Thanks so much for
Bye.
having
Thank
me.
you.
All right, bye.